This is a classic case of a very high-risk patient who 2 years before they presented with metastatic disease, to no surprise, had multiple positive lymph nodes. So I think it is, again, not very surprising that some 2 years later, this is a patient who presented with a performance status of 1 and disease that was quite symptomatic in the bones and other organs. So this is obviously a patient with M1c disease. I think you have luckily for the patient, two very good choices. I would tend to treat a symptomatic patient where I had a gut feeling of a rapid pace of disease who was V600E mutated. I would tend to treat those patients with BRAF plus MEK, and again, you can use dabrafenib, trametinib, or vemurafenib, cobimetinib. Either way, I think you'll get a rapid response. Could you use an alternative? Could you use immunotherapy with IPI plus nivo or ipilimumab with nivolumab? I think that would also be a reasonable choice. I tend to like the theoretical concept of giving a brief burst of BRAF plus MEK therapy, which we know from work by Jen Wargo and others will cause an influx of T cells into the tumor. How long that will last is not clear. It may be as short as 4 and as long as 8 weeks, but giving 4 to 8 weeks of BRAF MEK to get a quick response. And then, and again, I'm not saying this is an official approved regimen, you could then switch to immunotherapy for what you hope would be a relatively long-lasting response. That being said, if this were a patient who achieved a rapid, complete response, there are those who would argue you should simply continue the BRAF plus MEK drugs. But in a symptomatic patient with a high disease burden that's got rapidly progressive disease, I think that is certainly a reasonable place for BRAF plus MEK therapy. Could you use immunotherapy combination of ipilimumab, nivolumab? The answer is yes, but I think when you need to get a quick response, as long as you know the BRAF status, you can't beat BRAF plus MEK drugs up front.